David Liew here from Eular 2024 in sunny-ish Vienna, and here to talk a little bit about one of the most anticipated abstracts, the Select GCA study, which was presented as a late-breaking abstract today, PBA LBA 0001. So the late-breaking abstract was for the study that looked at upadacitinib versus placebo in giant cell arteritis. And we'd already heard that there was a positive result in a press release about 2 months ago. And so everyone's really interested to see what the actual results look like. So this study looked at two different doses of upadacitinib, 7.5 milligrams, that's half of our normal rheumatoid arthritis dose, and 15 milligrams daily. And in fact, the 7.5 milligrams daily just missed out on hitting the primary endpoint. So the p-value was 0.057, so just missed out on that. But the 15 milligram well and truly hit the primary endpoint, which was the proportion of patients achieving sustained remission from week 12 through to week 52. And we saw that at 46% in the upadacitinib 15% group versus 29% in the placebo group. So I think that's quite a nice result. I mean, it's certainly of the magnitude that maybe we would have expected from tocilizumab as well. They did a whole lot of secondary endpoints, and you can see actually that the steroid spared is about over the course of the 52 weeks. They gave upadacitinib a 26-week taper versus a 52-week taper in placebo, and that saved about 1.2 grams of prednisolone. And I think critically, what everyone was looking for was about the safety, because and inevitably there was a question about, well, given the regulatory safety warnings, should we be, and thinking about the kind of disease that GCA is with relatively high median age, is this the kind of thing where we should be using a JAK inhibitor? So firstly, to say, within this 12-month period of time, of all the types of things that you might be concerned about, actually, upadacitinib came out really well. So major adverse cardiovascular events, there were 2 in the study, both were which in the placebo arm. Serious infections were actually lower in the UPA groups versus placebo groups, probably because of the steroid. And I think it's a good opportunity to remind ourselves steroid is what drives a lot of this in terms of a problem. And actually, there wasn't really much of a zoster signal either. And malignancy, we didn't really see much, although it's too short of a period of time as well. Nevertheless, I think it makes a really interesting point, and one actually that came up in my debate with Janet yesterday, which is really about in terms of when we're trying to assess JAK inhibitor safety, we've got to think about what disease we're looking at and what the comparator is. And frankly, when the comparator is glucocorticoid, then that's a problem. And I think we've got to also think that maybe tocilizumab, which is the other currently approved alternative to upadacitinib for giant cell arteritis, that there's increasing questions about whether that's doing enough overall to truly suppress the disease, and especially at a vascular level, and whether it will actually truly wash out to prevent as many ischemic complications and vascular remodeling issues as we might think it might hope it would do otherwise. So really a lot of space there for UPA, some really exciting results there. Obviously, like to see the full paper in due course, like to see extension data, like to see structural outcomes and long-term safety. But also, I think we're getting to the point that now, if we're starting to see more agents, really love to see a head-to-head between upadacitinib, tocilizumab, maybe secukinumab if it washes out in G-Captain. Plenty more to watch in this space. For plenty more on all of Eular 2024, rheumnow.com.